I was asked to talk about chemotherapy in melanoma, and I think it was interesting or telling that it was the only talk on that topic, which shows there's very little interest in that particular area. We spent 20 years trying to advance chemotherapy in melanoma and made little progress in that, either with the conventional treatments or with the newer drugs. And I suggested that there were three pillars to treatment for advanced melanoma: targeted therapy, immunotherapy, and chemotherapy. But in fact, for the vast majority of patients, chemotherapy has little role. I then looked at some of the subgroups of patients with melanoma who do not do well with conventional chemotherapy or conventional treatments, and so that would include patients with mucosal melanoma, patients with eye melanoma, uveal melanomas, and also the patients who fail standard therapies. And for uveal melanoma who don't benefit from immunotherapy, I showed, based on the recent SUMIT study, there was no benefit from chemotherapy. For mucosal melanoma, I showed data to suggest there may be a temporary benefit in a subgroup of patients. And then I finished by suggesting, one, we need to do a lot more work in this area and to devote some of the attention that we're devoting to the newer treatments and some of the mechanisms. So we do a lot of molecular profiling on patients with tumors, and we can follow patients sequentially, and in that way we can sometimes identify patients that might respond to chemotherapy, and I gave an example of that. And then I also suggested who you might consider chemotherapy for, and essentially it's right at the end of the treatment algorithm. It's for the fit patients who you've run out of options and you don't have an appropriate clinical trial. So it wasn't a very upbeat presentation, but I think it was a realistic presentation about what the standard of care is at present.